More people are still joining. By 5:05, we'll start. All right, good evening, everyone. You are welcome to the Intensive and Critical Care Society of Nigeria bi-monthly webinar series number 33. Our speakers are set to deliver the presentation. So I would like to invite the president of the association, Dr. Job Otokwala, for his opening remarks. Dr. Job, over to you, sir.
Good morning for our colleagues who are over there in Hong Kong. I mean, it's a big privilege for us to have had you stay up to this moment to talk to us. And good evening for our colleagues in Nigeria. It's a big privilege for us to have these very eminent colleagues talk to us on a very important topic, mechanical circulatory support, which everybody has to know. There's no one who works in the ICU, who works in cardiac surgery. I can see Dr. Ikutu online. I can see very prominent members of our society who also practice cardiac and cardiothoracic surgery. Even those who work even in normal general ICUs, who have to experience circulatory collapse. This topic is extremely important to us. So we thank you and welcome everyone. And then we hope that at the end of this section, we'll have something to go home with, something that is very practical, not just the theoretical aspect of it, something that is very practical that we have to learn, and then we'll make it make it easier for us to appreciate and understand as well. Thank you very much. Thank you and welcome. I want to also welcome our moderator, Dr. Owoade, who is online. I'm sure at the end of the day, we'll gain something from it. Thank you and God bless.
Thank you, Mr. President. I would like to hand over to the moderator of the webinar, Dr. Aderonke Owoade, who is a consultant critical care physician at African Medical Center of Excellence. Over to you, Dr. Owoade.
Thank you very much, Dr. Josiah. Good evening once again. Good evening, Mr. President. Good evening to our speakers for today. It's a privilege to be able to moderate this great session. Without further ado, I will introduce our first speaker, who is Dr. Tammy Ma. She's a critical care specialist with focused expertise in extracorporeal cardiopulmonary resuscitation, mechanical circulatory support, advanced hemodynamic monitoring, and critical care echocardiography. She graduated from the University of Hong Kong in 2014 and completed her fellowship training in critical care medicine in 2021 at Queen Mary Hospital's Adult Intensive Care Unit in Hong Kong, the ECMO Center, and also Platinum Center of Excellence. She serves as a team leader of ECMO and Impeller, and she has developed substantial experience managing patients requiring extracorporeal circulatory support, ECMO, Impeller, ECPELLA, and intra-aortic balloon pump support. Her echocardiography credentials include the AXESAM and SEXESAM diplomate plus transesophageal echocardiography certification, and also a fellowship of the American Society of Echocardiography achieved in 2022, 2024, and 2025, respectively. These qualifications support her work with patients who have complex hemodynamics, including heart transplants, recipients, patients supported with left ventricular assist devices, and patients with advanced heart failure. She is actively involved in research on ECMO, flow titration, impeller weaning, and heart-lung interaction. And she has served on the faculty of also endorsed ECMO course in Hong Kong since 2022. Dr. Tammy, once again, welcome. You have 25 minutes. Please proceed with your presentation. Thank you very much. Hi, Dr. Tammy, we can't hear you.
Hi, can you hear me now?
Okay, yes, very well. Yes, we can. Thank you.
Hi, thank you for the kind introduction. It is a real honor to be here and to share this section with you. To start with, about 10% of STEMI patients develop cardiogenic shock, still the leading cause of in-hospital death after MI. Even with early revascularization, 30-day mortality remains up to 50%, unchanged for the past 20 years. What has evolved is the manner in which we provide support. Between 2011 and 2018, the usage of balloon pumps decreased from 45 to 33%, whereas the adoption of newer devices increased approximately sixfold. Despite the static mortality rates, the proliferation of devices has not translated into improved survival outcomes, which direct us to the focus of today's presentation. I'll split the presentation into two parts. First, I'll discuss the devices, the mechanisms of actions, indications, limitations, and the most recent evidence and guidelines. Then I will focus on the cardiogenic shock itself, its definition, staging, guideline recommendations, and the implications for escalation, timing, and device selection. Afterwards, my colleague Wincy will guide us through echo monitoring through MCS. Let's start. First, IABP is a balloon pump that sits in the descending aorta and works by counterpulsation, timed to the cardiac cycle. It inflates in diastole, augmenting diastolic and coronary perfusion pressure, then deflates just before the systole, dropping the afterload so the ventricle ejects against less resistance. The net effect is a modest increase in the cardiac output. Its main advantage is practical. It is the easiest and fastest device to place percutaneously. It still earns its place in mechanical complications of MI and as a bridge to decision. The drawbacks are that it does not actively unload the LV volume or offer extra oxygenation. For decades, the balloon pump was the standard support in infarct-related cardiogenic shock, on exactly the physiology we just described. The IABP Shock 2 study was a randomized prospective multicenter trial that tested that belief on patients with MI complicated by cardiogenic shock. The results were disappointing. There is no significant difference in 30-day mortality nor in the time for hemodynamic stabilization. And on the first plot, every subgroup sits around a relative risk of 1. What is the reason that IABP, despite having such favorable physiology, has failed to reduce the mortality rates in patients suffering from cardiogenic shock? It comes down to what is limiting the circulation. The pump gives a large fall in afterload, but only about half a liter per minute for more output. In AMI shock, the limit is pump failure, an abrupt loss of contractile mass. So half a liter actually changes nothing. In contrast with decompensated chronic heart failure, it is adapted, congested, vasoconstricted, sitting on the steep afterload sensitive curve. A small drop in afterload buys a large stroke volume gain. The best case patient is Sky B to Sky C with mild shock, with a preserved RV, and in afterload sensitive situations. This is exactly what the guideline says. Both the guidelines now advise against routine balloon pump use in ACS-related cardiogenic shock, a Class 3 recommendation. What they preserve is the niche Class 2A for ACS-related mechanical complications such as post-MI VSD and acute severe MR. Both are afterload dependent, so counterpulsation buys forward flow while the patient is stabilized for repair. Outside that, it has no routine role. Next, Impella. It is the microaxial pump sitting across the aortic valve, continuously and actively pumping blood out of the ventricle into the aorta. It directly unloads the LV, lowering the wall stress and oxygen demand while restoring the forward flow. This family of devices includes the 2.5 and CP, which are percutaneous, with the CP serving as the workhorse. The 5.0 and 5.5 are surgically implanted for comprehensive support, while the RP is designed for RV. Due to the limited time, today we will focus only on the LV support. A key point to note is that all the left-sided devices depend on LV preload. They can only pump as much as the RV supplies allow. That means the RV needs to be functioning properly. Then how should we assess the patient? We need an echo and a PA catheter. I will delegate the echo part to Wincy and focus on the PA cath result here. The first number is the cardiac power output, CPO calculated by MAP times cardiac output over 451, the strongest hemodynamic predictor of mortality in shock. Below 0.6 or below 0.8 on inotropes, MCS has to be considered. The second number, pulmonary artery pulsatility index, PAPI, calculated by pulmonary artery pulse pressure over the right atrial pressure, tells you which side is falling. Below 0.9 means that the RV is failing, so support the RV is needed. Above 0.9, the RV is competent and you can focus on the left side. Other signals of RV failure includes a rising CVP over the wedge ratio, and frequent suction alarms. Of course, echo are also very important. They all tell the same story. Our goal for Impella support is CPO of at least 0.6, ideally around 0.8, and we adjust the support levels according and we assess the patients regularly. The danger shock is the trial that changed the conversation. It enrolled 385 adults with STEMI-related cardiogenic shock, randomized across European centers to receive either an Impella or standard alone care. After 180 days, there was a reduction in mortality from 58.5% to 45.8%, representing the first randomized evidence of a survival benefit through active LV unloading. But look at the other bar. Safety events were 4 times as common: bleeding, limb ischemia, and renal failure requiring dialysis. So the benefits are real, and so is the price, which is exactly why patient selection matters. Due to the promising results observed in the trial, the 2025 AHA guideline gives a Class 2A recommendation for the use of a microaxial flow pump in carefully selected patients suffering from STEMI associated with severe or refractory cardiogenic shock. It is important to note the specific phrasing, selected patients, and those with severe or refractory shock, rather than all patients experiencing shock. Also, the guidelines endorse short-term mechanical support as a bridging therapy to surgical intervention in cases of mechanical complications. The message here is not that Impella is superior to a balloon pump in all situations, but that for correctly identified phenotypes, actively unloading the ventricle is now backed by guidelines. Next, VA ECMO. The circuit drains venous blood, passes it through a pump and an oxygenator, and returns it to the femoral artery. 2 things make it unique. It is the only device here that also provides gas exchange, and it is biventricular by design. It bypasses both ventricles, so it does not matter which one has failed. In effect, it can completely substitute the native cardiac function, which is why it is preferred in SCI shock and refractory cardiac arrest. The trade-offs are equally significant. It increases the LV afterload, so the ventricle may need venting, and the cannula can cause bleeding and limb ischemia as well. Given the substantial impact, one would expect the trial data would be conclusive, and let us examine the randomized data. Now, the evidence for VA ECMO. A very sad table because every 9 is actually negative. The ECLS Shock 1 randomized patients after revascularization and found no significant improvement in the EF. ECMO-CS in rapidly deteriorating shock showed no reduction in death or escalation to other support. ECLS shock, the largest trial ever, found 30-day mortality essentially the same, with significantly more bleeding and limb ischemia. Euroshock was stopped early and underpowered, showing a lower mortality rate, but not statistically significant. And when the individual patient data from all 4 trials were put in the Lancet meta-analysis, as expected, there is no survival benefit and a consistent excess of bleeding and vascular complications. So, on the face of it, routine early ECMO does not save lives in infarct-related shock. But before we discard the most powerful device we have, we need to ask whether these trials were designed to show a benefit at all. So, why were they all neutral? Look at how the trials were built. The pilot was tiny, single-center, with EF as endpoint instead of survival, and almost all patients resuscitated first. ECMO-CS and ECLS shock both enrolled very sick, largely post-arrest patients, and had substantial crossover. Euroshock stopped early with a confidence interval so wide it actually tells us nothing. Each of these features tends to reduce the result towards 0. Crossover dilutes the contrast between arms, and a case mix dominated by post-arrest patients means many were dying of anoxic brain injury, not low cardiac output. Something not pump can fix. So the honest reading is not that ECMO fails, but that routine, early, and selected use is unproven. Selection and timing are doing the real work, which brings us to the bedside question: which device for which ventricle? Currently, no randomized head-to-head trials compare ECMO and Impella. Existing evidence comes from the 5-propensity mesh score. When combined, the data favor Impella in cases of cardiogenic shock, showing improved short-term, in-hospital, and 30-day survival, along with fewer bleeding events requiring transfusions. This aligns with the physiology of LV dominant shock, as Impella directly unloads the LV without increasing the afterload. But look at the RV subgroup. The odds ratio is 1.71, favoring the VA ECMO with a confidence interval of 0.8 to 3.6. There may be a signal indicating that VA ECMO is more effective in RV failure. Practically, LV dominant shock with a working RV, which for Impella. When the RV fails or gas exchange is lost, add or switch to ECMO. So what is the stance of the guidelines on this matter? The 2021 ESC heart failure guideline states that short-term MCS should be considered in cases of cardiogenic shock, serving as a bridge to recovery, long-term support, or transplantation in selected case. In contrast, the 2025 AHA guidelines has become more precise and restrictive, stating that routine VA ECMO for ACS-related cardiogenic shock shows no benefit, supported by level B randomized evidence, in line with findings from the ECLS shock and the meta-analysis. When considered collectively, this does not imply ECMO is unnecessary. Rather, it is unselective routine use in infarct-related shock is unsupported. Instead, a targeted bridge-to-decision approach remains appropriate, emphasizing patient selection. Notably, evidence is clearly positive in one context, the refractory cardiac arrest. Here is the setting. Arrest trial was a phase 2 single-centered randomized trial focusing on the out-of-hospital arrest in patients with refractory VT-VF. They were randomized to ECPL or continued ACLS. The trial was stopped prematurely after 30 patients due to strong evidence of efficacy. Survival to hospital discharge was 43%, that means 6 out of 14 with early ECMO, versus 7%, 1 out of 15 with the ACLS group. Crucially, look at the right-hand panel, survivors from the ECPR group. They left hospital with largely preserved cerebral performance and stayed the way at 6 months, while the only survivor from the ACLS group died 3 months after discharge. So ECPR offers more than just a pulse. It provides meaningful survival. The guidelines have moved quickly. In 2020, the AHA looked at ECPL and concluded there was insufficient evidence to recommend routine use, Class 2B Level C. By the 2023 focus update on advanced cardiovascular life support that become a Class 2A Level B. ECPL is reasonable for cardiac arrest refractory standard to ACLS. 2 qualifiers carry the whole recommendations. flu though. First, in selected patients, so weakness arrest, shockable rhythm, short no-flow time, and no significant comorbidity. Second, within a trained and equipped system of care, a team that can cannulate fast and reliably at any hour. ECPR is a systems intervention as much as a device. Without the pathway, the trial results do not transfer. With that, let us step back and put these three devices side by side. Let me put this, look at this together. The balloon pump is passive. It displaces blood in the aorta, adds under a liter a minute and reduces afterload, and it needs ventricles that still ejects and a rhythm to time against. Impeller is an active microaxial pump, drawing blood from the ventricle straight into the aorta. It unloads the LV directly and keeps flowing even when the aortic valve never opens. But it depends on a RV that can fill it. VA ECMO takes over the circulation outright, through flow biventricular by design, and the only one that adds gas exchange at the cost of raising LV after no. So the latter is defined by what the heart can still do. The balloon pump needs ventricles eject, impeller needs RV, and ECMO needs neither. After understanding the devices we have, let's move to the bedside. So what is cardiogenic shock? Classically, a primary cardiac disorder causing sustained hypotension and hypoperfusion despite adequate filling, resting on three pillars. Hypotension, a systolic under 90 or drugs needed to hold it there. Hypoperfusion with altered mentation, cool peripheries, low urine output, and a raised lactate, and hemodynamic confirming pump failure rather than hypovolemia. The hypoperfusion pillar is the one that matters. A number on the monitor is not shock. Hypoperfused organs are. But notice this definition captures only the sickest end of the spectrum with a rigid threshold, and that is exactly its problem. So why isn't that definition enough? Two problems. First, it is one size fits all. A single fixed cutoff puts a hugely varied population under one label, in shock or not. There is no gradation, so the pre-shock patient, the classic patient, and the refractory patient all look identical on paper. Worse, it misses the patient who is quietly deteriorating but not yet frankly hypotensive, the one we still have time to help. Second, it cannot guide management. A yes or no diagnosis tells you nothing about how aggressively to treat when to escalate, how intensively to monitor, and what to expect. The same label covers a patient stable on a single inotrope and one who needs mechanical support tonight. What we need instead is a graded dynamic language for severity, and that is the SCAI shock classification. This is that language. SCAI 5 stages, A to E. A, at risk, low shock but vulnerable, 3% mortality. B, beginning, relative hypotension, perfusion still intact, 7%. C, classic hypoperfusion needing intervention, 12%. Then look at what happens. D, deteriorating failing to respond, 40% mortality. And E, extremis, 67%. The relationship is not linear. From A to C, its rise is gentle, but between C and D, it is a cliff. Mortality more than triples in a single step. That is the message of this slide. Once a patient slides from C to D, we are no longer treating shock, we are chasing it. The window to act is before D. Validated in over 10,000 CICU patients, each stage is an independent predictor. So does acting early actually change outcome? And actually, it does. This is the National Cardiogenic Shock Initiative. 406 patients are on a protocol built around early support. Support went in before PCI in most patients, unloading the ventricle before revascularization, and raising the mean pressure and cardiac power output and improving the lactate clearance. Overall survival to discharge was 71%, against roughly 50 historically. But the comparison that matters is by stage. In SCAI C or D, 79% survived to discharge, and 62% to a year. In stage E, 49 and 32%. And here is the detail that counts. Procedural survival was essentially identical. We can get the device in either way. What differs is everything afterwards. And which raises the question, why does support so often fail once the patient reaches extremis? Because by extremis, the problem is no longer just the pump. Sustained hypoperfusion sets off a cascade. Oxygen depth and acidosis, then a cytokine surge and nitric oxide release. then vasoplegia and capillary leak, and finally multi-organ failure. And here is the point. By stage E, that cascade is self-perpetuating and often irreversible. A pump can restore blood flow, but it cannot switch off the established inflammation. That is why timing beats hardware. The same device put in earlier is treating a problem that is still reversible, which is why the first 24 hours matter so much. How often should we assess? This study says every 4 hours. Nearly 3,000 cardiac ICU patients were scored in 6 4-hour blocks over the first 24 hours, and the stage climbs and falls between blocks. A worsening spell is only caused if you keep scoring. And the mean of these readings discriminated best, better than admission stage or the worst single reading. That actually makes sense because a higher average stage means the patient spend longer hypoperfused, and the longer that exists, the more severe the organ damage. The average captures the dose of shock, not just a peak. So let the running average, not the snapshot, drive escalation, which brings us to what exactly we should be scoring. And there's 4 complementary domains. The physical examination with hypotension, tachycardia, and the bedside signs of hypoperfusion. Biochemistry, the renal liver function with lactate as the key marker. Hemodynamics, from blood pressure to filling pressure and cardiac output. And therapy, how much support the patient has been receiving. The last one is easy to overlook, but the dose of support required is itself a measure of severity. These are all routine ICU data, which is why SKY travels beyond the cardiac ICU. Read every domain together, but not single captures. In summary, cardiogenic shock isn't a switch, it's a spectrum. That's why we stage it with SKY, a 5-tier scale from A to E that maps directly onto mortality. It gives the whole team one shared language, so everyone knows exactly who needs closer watching and who needs to escalate. But staging isn't a one-time snapshot. Patients shift SKY class within the first 24 hours, and reassessing roughly every 4 hours across exam findings, lactate, hemodynamics, and support predicts outcome better than the initial admission grade. That trending data matters most when it tells us what to act. A patient stuck at SKY D or one who simply isn't improving needs escalation before they reach extremis. And once we have staged the patient and recognize that they are not improving, the next question is no longer whether to escalate, but which device best matches the stage and physiology. This algorithm that comes from the 2025, the ACC Expert Consensus Statement on Cardiogenic Shock. It sets out for a heart failure patient in shock what to weigh up before committing to mechanical support, and then how to match the device to the patient. I would take this into 2 parts. The first part is the blue box, the practical considerations we should work through before any device goes in, and I will go through those one by one, all except the shock severity and shock profile. These 2 I will keep for the second part because that is where the staging links back to the devices we have just discussed. So before we escalate, there are 6 practical considerations sitting alongside the shock severity and profile. First, the exit strategy. We need a clear goal for our MCS, as it's only a bridge to definitive therapy, not a curative treatment. Second, hypoxia. If gas exchange is failing, flow alone will not rescue it, and that points toward a device with an oxygenator. Third, arrhythmia. Significant arrhythmia can restrict the ability of IABP, and also refractory VTVF also undermines any pump that depends on ventricular ejection. ECMO has to be the choice. Fourth, the anticipated duration of support, which drives cannula choice, anticoagulation, and also hemolysis risk. Fifth, the ability to ambulate, as axillary access enables rehabilitations and preserves transplant candidacy. Lastly, contraindications such as aortic dissection, bleeding risk, etc., which may impede our ability to proceed. With these 6 settles, then we can now match according to the severity and profile. This line is really about reducing the device selection to 2 practical bedside questions. First, how big is the support gap? In other words, how far is the patient from adequate perfusion? And second, which ventricle can still fill the pump? At the SKY B end, the support gap is still relatively small. These patients have hypoperfusion beginning, so the priority is usually medical treatment first. And if you need mechanical support, IABP may be enough because the native ventricle is still ejecting and counterpulsation still has something to work with. The amount of support is modest, but sometimes that fall is afterload is like exactly what the patients need. Once you move into like Sky C or Sky D, the gap is larger. If this is an isolated LV failure, then LV pump like impeller makes sense because it directly unloads the LV and provides forward flow. But that only works if the RV can still deliver preload across the lungs and into the left heart. In other words, even the best LV pump cannot pump what the RV does not deliver. If the RV is failing, or if this is a biventricular shock, then the question changes completely. In that setting, isolated LV support is not enough because the pump will be underfilled. That is where VA ECMO or an RV support strategy on top of LV support becomes more appropriate. And by Sky E, the support gap is maximal. This is refractory shock with multi-organ failure where only ECMO can truly replace the circulation and fluid flow, provide gas exchange, and also support to those ventricles. So, in summary, 3 things to take back to the bedside. First, physiology. Match the pump to the failing ventricle. The balloon pump needs ventricles that still eject. Impeller needs a RV that can fill it. And also, the ECMO needs neither, but pays for watch with the afterload. Second, evidence. Benefit is phenotype specific. The trials were neutral in unselected shock, yet danger shock showed a survival gain when the right patients were chosen. And for timing, stage carries the mortality gradient. Support pays off in stage C and D. By extremis, the inflammatory cascade is self-perpetuating and no pump can redo it. So stage it, restage it, and escalate before the extremis. Before every escalation, ask 2 questions. How large is the support gap and which ventricle can still pump? None of these can be answered without imaging, and that is where I will hand over to Dr. Wincy Ng, who will take us through the echo assessment before and during the MCS. Thank you.
Thank you very much, Dr. Tammy Ma. That was a really interesting one, introducing us to the devices and also a brief on circulatory shock and how to pair the right device with the right clinical condition. So I'll be introducing Dr. Wincy Ng, who is currently an associate consultant of the Adult Intensive Care Unit at Queen Mary Hospital in Hong Kong. She is also a honorary clinical assistant professor of the Critical Care Medicine Unit at the University of Hong Kong. She obtained her medical degree from the University of Hong Kong in 2014 and completed her specialty training in critical care medicine in 2021. Her areas of interest include critical care echocardiography and extracorporeal life support. She obtained the European Diploma in Critical Care Echocardiography EDEC in 2024 and is currently an EDEC supervisor. She attained the diplomate status in critical care plus transesophageal echocardiography of the National Board of Echocardiography in 2025 and became a fellow of the American Society of Echocardiography in the same year. She is actively involved in echocardiography education in the Asia Pacific region, including Hong Kong, Macau, Singapore, and Indonesia. Internationally, she has been invited as speaker and instructor in echo workshops in conferences such as CHEST, International Symposium on Intensive Care and Emergency Medicine, World Congress of Anesthesiologists, and the Asia Pacific Extracorporeal Life Support Organization conferences. Once again, welcome, Dr. Ng. You have the floor. Thank you very much.
Thank you very much for the kind introduction, and I'd like to thank the organizers for the invitation. I hope my slides are showing up, and I hope they are advancing. So I have nothing to declare. So my job here is to walk you through how echo can be of help in all the phases of device use. So that would include pre-implantation, placement, monitoring, and weaning. And we're not going to cover weaning today because that by itself is a 1-hour lecture. So hopefully I would be able to cover the rest 3 phases within the time limit. So first of all, pre-implantation phase, it's very important to use echo to determine and estimate the severity of cardiogenic shock and to identify any mechanical complications in AMI cardiogenic shock. Do a hemodynamic phenotyping of cardiogenic shock in order to choose the correct device to use, and also to identify any device-specific contraindications prior to implantation. And I'd like to introduce you to this very comprehensive review that I was very lucky to be writing with my European colleagues on current perspectives on in cardiogenic shock, where there is a template on management of cardiogenic shock. And as Tammy has already spoken earlier on very clearly, that we must deploy mechanical support before irreversible damage happens. And so we do not wait until stage E, and if possible, we would like to deploy a device as early as possible. And my job here is to talk about how we can use echo to help with that. And Tammy has just now talked about how the PA catheter would be useful. And that would, of course, be a gold standard, but that is an invasive device and may not be readily available in all centers. While for echocardiography, it serves as an estimate and a surrogate for stroke volume in cardiac output. I'm not saying that is very accurate. It's very operator dependent, and it's also not a continuous monitoring. So there are a lot of setbacks, but it's also non-invasive. It's easily repeatable, and you can do it anytime at the bedside, as many times as you want. And so it's indeed a very important tool to use, not as a sole trigger for mechanical support, but complementarily with, for example, PA catheters. And anything of a LVOT VTI of less than 8 to 10 would be predict poor prognosis for these patients. Secondly, we would like to identify any mechanical complications prior to implantation in an AMI cardiogenic shock. For instance, papillary muscle rupture, where you'll be able to see a patient with severe cardiogenic shock, acute pulmonary edema, and on echo, you may be able to see a mobile mass that is the papillary muscle that's ruptured itself, associated with severe MR. The second mechanical complication to look out for would be ischemic ventricular septal rupture. So as you can see in this patient, which I've managed in my unit, a patient with full thickness infarct over the apical area, and that's confirmed by color Doppler that shows flow across the interventricular septum from the left to the right side, indicating a left to right shunt because of that ventricular septal rupture. And of course, also free wall rupture, where you'll be able to see a rim of pericardial effusion, which is not only hypoechoic, but also with hyperechoic material inside, indicating of blood products and active hemorrhage. And it's very important to identify these mechanical complications early on, because they cannot resolve on their own without surgical intervention. And it's not useful to put these patients just on a mechanical support and wait for them to recover, because they will not. So always important to identify these complications beforehand. Thirdly is to do a hemodynamic phenotyping in order to choose the kind of support to put these patients on. So we can broadly divide them into a left ventricular dominant, right ventricular dominant, and biventricular cardiogenic shock. And out of these three, the biventricular phenotype would pertain the worst prognosis. So in a LV dominant cardiogenic shock, we'll be able to see a dilated LV with a very poor LV systolic function and EF of around 10 to 20%. And in this particular patient, the LVOT VTI is only 4 centimeters. So anything less than 8 to 10, again, would pertain to worse prognosis. And in these patients with only LV failure, isolated LV failure, then we would consider to put these patients on a left-sided support. And depending on the degree of severity, as Tammy has very adequately explained before, we can either put them on a balloon pump, an impeller device, or a VA ECMO according to increasing severity of these patients' cardiogenic shock. The second would be a right ventricular dominant cardiogenic shock, where on echo you'll be able to see a dilated right ventricle with severely reduced RV systolic function. And in patients with pulmonary arterial hypertension, you'll be able to see evidence of increased pulmonary arterial pressures that would include a shortened pulmonary acceleration time and also sometimes a mid-systolic notch that you can see here as shown. And so for patients with an isolated RV failure, we can put them on an isolated RV support, such as an impeller RP or a VA ECMO with Protect Dual cannula system. And the last phenotype to look for is biventricular cardiogenic shock, where these patients would have dilated LV and RV, and both ventricles has severely depressed systolic function. And for these patients with a high severity and worse prognosis, the only device that we can consider would be VA ECMO with or without subsequently an LV venting device. And lastly, after being able to identify the kind of indication and choose the subsequent device to use, we would also like to look for any device-specific contraindications prior to placing them on the exact device that these patients need. So for VA ECMO, they are reserved for the most severe kind of cardiogenic shock with biventricular failure, and in patients in extremis, patients with ECPR, that would be the device of choice. And it's very important to look for any aortic dissection or severe aortic regurgitation as contraindications to these devices, as shown here on these echo images. And what about impeller? So we would consider impeller in patients with isolated LV dominant failure, or in a patient being put on VA ECMO used as a means for LV unloading. And the contraindications for impeller use would be those that were talked about for VA ECMO support. And additionally, we would also look for any intracardiac shunts. For instance, the same case of a ventricular septal rupture, as said before, that would be a contraindication for the use of impeller if we know that prior to placing these patients on a device, we would try to avoid the use of an impeller. And second would be any intracardiac thrombus. For example, in this echo shown, a LV thrombus, which would be a very bad idea to put these patients on impeller support, where the thrombus would be just spread systematically throughout the body. So it's very important to look for contraindications prior to putting them on the devices. And so this is just a short summary for the pre-implantation phase. It's very important to look very carefully and do all the preparations you can prior to putting these patients on a device. So remember, determine the severity of cardiogenic shock with your LVOT VTI as an estimation. Look for any mechanical complications in AMI cardiogenic shock. Do a hemodynamic phenotyping and identify the kind of devices that you would want to put your patients on, and then identify device-specific contraindications prior to implantation. And second, that would be the placement phase, where for VA ECMO, it's if possible, we would want a real-time guidance for VA ECMO placement and also confirm the cannula is in its correct position after placement. So during placement, we would like to visualize the guide wire passage. For the venous side, it would be a guide wire through the IVC, while the arterial side, we would want to look at the guide wire in the thoracic aorta. And it's important to look for, to properly confirm your guide wire is the right position before you proceed to dilation and also ECMO cannula placement. So this is a video taken as we were doing a transesophageal echo for our patients during VA ECMO implantation. This is the venous side, and what you're looking at is this transesophageal bicaval view, where you can see on the left side, that would be deployment of the guide wire that goes all the way from the intrahepatic IVC into the right atrium. And once we've confirmed that the guide wire is in the correct position, then we can deploy the cannula itself through the guide wire. And now we can confirm as well that the cannula is in its right position. The same thing for arterial cannulation. Here you can see in the same patient, we are confirming that the guide wire can be seen in the thoracic, the descending thoracic aorta in both its short axis and its long axis view. And so once we see that guide wire is properly confirmed, then now we can confirm the cannula position after placing the actual cannulas in. So the venous cannula, the tip of it should be somewhere between it should be above your IVC to RA junction and somewhere from there to the mid-RA cavity. And the arterial cannula is not usually seen on echo because of its very low position. So this is confirmation of the venous cannula position for this patient on VA ECMO. So we want to make sure that the cannula tip is not too shallow. If it's in the intrahepatic IVC, then it's too shallow. And we also want to ensure that it's not too deep into the RV or abutting the tricuspid valve. And we would also check for any wall impingement, for example, the RV, the lateral RA wall or the interatrial septum. As for the other devices, impeller and IBP, they're usually placed under fluoroscopic guidance rather than transesophageal guidance. And however, we can confirm their position placement afterwards. For impeller, we can do either transthoracic or transesophageal echo, and I'll show you examples of that. It's very difficult to confirm the IBP position to be in the correct position on transthoracic, so it's probably done on transesophageal more, and it's hardly routinely done. We usually just do a chest X-ray. So confirming impeller position on transthoracic, we look at the distance between the aortic valve to the inlet area. So we expect the distance to be around 3.5 centimeters for an impeller CP and around 5 centimeters for an impeller 5.5. As you can show here, this is where we measure from the inlet to the aortic valve level. So I'm beginning by with a case. I'll go over this very quickly because of time constraints. So this is a 60-year-old patient with known ischemic cardiomyopathy coming in for acute decompensation and a PA arrest. And you can see after arrest, this is the heart after ROSC. You can see a markedly dilated LV with very poor and severely depressed systolic function. And that's the 4, 2, and 3 chamber views. You can see the heart is barely moving, and there's spontaneous echo contrast within the LV cavity. And if we measure the LVEF, it's only something and with a depressed systolic function, with tissue hypoperfusion as well. And eventually, the device of impeller CP was inserted first, just to see how he or she responds to it. And that's the impeller, and we can measure from the inlet to the aortic valve level, and the distance is slightly more inwards than we expected at a distance of 4.2 centimeters. And I'd just like to show you how the color Doppler would look like when you place patients on impeller. There are a lot of low interference, so a lot of times you can't really determine or interrogate Doppler measurements while these patients are on impeller. So it's perfectly normal to see all these mosaic pattern and interference when these patients are on impeller. So what to do when your transthoracic view is suboptimal? Now we can also do transesophageal, and the way to measure it is exactly the same. We do it on the mid-esophageal long axis view at 120 degrees, freeze the frame, and we measure from inlet to aortic valve level as shown here. The distance is 3.1 centimeters. And in the monitoring phase, it's also very important to look for any need for LV unloading and also assess for any complications. So firstly, for LV unloading, I'm going over very quickly another case to illustrate how important it is. So we have a very young patient here, just 29-year-old with unremarkable past health. He sustained an out-of-hospital cardiac arrest witnessed by his girlfriend. That started an eCPR call in the middle of the night, and VA ECMO was set up after a total low flow time of an hour. And we started unfractionated heparin for these patients. And overnight, the arterial line was almost flat. And a few hours after setting up the ECMO, there was a suspected intracardiac thrombus. And so we did transesophageal echo for this patient. So here is the mid-esophageal four-chamber view where you can see in the LA and the LV, there are a lot of hyperechoic material within the cavities, suspicious of thrombus formation. And if we turn to the mid-esophageal aortic valve short axis view, we can see that the aortic valve is hardly moving, is hardly opening, and there are a lot of hyperechoic material or spontaneous echo contrast that is existing at all the aortic cusps. And of course, there are also thrombus formation in the LA as well. And if we turn to the mid-esophageal long axis view, there we can see very significant thrombus formation at the left atrium, at the left ventricle. And if we look very closely at the interventricular septum, you can see that it's extremely thickened. So that raises the question of whether this patient is having an undiagnosed hypertrophic cardiomyopathy that is causing the cardiac arrest. And we also evaluated very in details the left atrium and also the pulmonary vein. And we can see that the multiple pulmonary veins are involved by thrombus formation. And for the interest of time, I'm just going to skip through those. And this is the aortic arch where you can see spontaneous echo contrast in. And that's as pointed by the arrow. That's what we call a mixing zone. And essentially, that's the zone where the native cardiac output meets the retrograde VA ECMO flow. And it's a zone of blood stasis. And so for progress for this patient, because of his very young age, we were very aggressively trying to treat him by proceeding to surgical intervention and clot evacuation. Despite all our efforts, unfortunately, this patient passed away. And intracardiac thrombosis is indeed a catastrophic complication that can occur in patients on VA ECMO support, and the mortality is 100% if untreated. And so once formed, the prognosis of these patients with intracardiac thrombosis can be markedly lower than those who do not. And so it's very important to look and assess for the need for LV unloading and to do it before any of these thrombosis formation occurs. So we can do that in a couple of different ways. So hemodynamically, we can look for a patient with a very low pulse pressure, an arterial line that is almost flat with a pulse pressure of less than 15 millimeters mercury. If your patient has a PA catheter in, look for a wedge pressure that is extremely elevated. That would give us the clue that this patient is having a severely distended LV and pulmonary edema. So clinically, you may be able to see a patient with malignant arrhythmia that is hardly controlled. That is a risk factor for inadequate LV unloading. And also clinically on imaging, you can see severe pulmonary edema. And because in this lecture, we are focusing on echocardiography, so we want to look for echocardiographic signs of need for LV unloading. And those would be a markedly dilated LV, blood stasis inside the LV cavity, but not to the point of thrombus formation, as you can see in the previous case. A lack of aortic valve opening is a really bad sign, and that would prompt for a need for timely LV unloading. And in a patient with pulmonary flow reversal, if you happen to have access to transesophageal echo and be able to look at the pulmonary veins, and a patient with severe mitral regurgitation, and of course, a very low LVOT VTI, indicative of very low LV ejection, then these patients are at risk of formation of intracardiac thrombosis, if not, if there is no timely LV unloading. And it's also very important to assess for any complications while on these devices with echocardiography. So these are all patients that we've managed before. So this is an unanticipated aortic dissection in a patient that did not have aortic dissection just after our ECMO implantation. So it occurred probably as a complication after coronary angiogram. And anyway, the patient was not crashing, and we were just doing a transesophageal echo for other purposes to look for evidence of infective endocarditis. And lo and behold, we can see this catastrophic complication where we had to put this patient off the device as soon as possible to limit the extent of complication. This is another patient with ECPR done for AMI cardiogenic shock, eventually with improvement in LV systolic function, but he remains in deeply comatose. And the CT brain showed multiple embolic infarcts, and that's what we saw on transesophageal echo. This is the bicaval view of this patient, where you can see a hyperechoic clot that is floating there adjacent to the venous cannula of the VA ECMO circuit. So this is a cannula-related thrombus formation. And we had to put that patient off ECMO as soon as possible as well. And this is another case where this patient was put on VA ECMO for massive pulmonary embolism, followed by catheter-based thrombectomy. And after the thrombectomy, this patient has severe hemodynamic deterioration, and transesophageal echo showed a significant pericardial clot. As you can see here, a hyperechoic layer of pericardial collection, which is indicative of blood collection. So this is probably the last case in my presentation. I'll skip through it very quickly because of limited time. So trying to assess for complications in patients on Impella. So this is a patient with a very marked anterior STEMI. Proceeded to primary PCI. It was done, and Impella was inserted because of the progressive cardiogenic shock. And despite that, this patient was on had a lot of uncontrolled ventricular arrhythmias and also a continuous suction alarm from the Impella. And despite the Impella, there's persistent loss in pulse pressure and evidence of hemolysis, which is a complication of Impella use. So we had to escalate this patient on ECPella support. And that would give us the question to think about what can cause suction alarms in Impella. And there are two major causes. So the first would be an inadequate preload, where these patients have a very small LV cavity size because of hypovolemia, and these patients would be prone to suction with an Impella in situ. And the other cause would be a markedly dilated RV that is causing shift of the interventricular septum towards the left side. And that would also cause the Impella to have suctioning effect. So we did transthoracic to rule out a very dilated right ventricle for this. And we also did give a lot of fluids to these patients in case he is hypovolemic, and there was no effect whatsoever for the suctioning alarm. And so we did an transesophageal echo to look for whether or not the Impella is malpositioned, causing the mechanical complication. And this is the transesophageal echo of this patient. You can see in multiple views that this heart is barely moving, and there are a lot of spontaneous echo contrast within the heart, despite on ECPella support. So this is the Impella device itself, and you can see despite the Impella device, there's still the aortic valve is still barely opening, and there's still a lot of spontaneous echo contrast, indicating that this Impella is not functioning well to do its job of LV venting. And if we look very closely, this is the transgastric view on the transesophageal echo. If I guide you through, and it with the yellow arrows, that is the actual pigtail of that Impella. And you can see that it seems to be caught on part of the LV wall or even the papillary muscle itself. So if I would rotate that pigtail for you to look at, so that's exactly where the pigtail is being engaged in. Is being embedded in the LV cavity and in between the two papillary muscles. Is caught mechanically in the papillary muscle, and that is why it's causing suction alarms. And so our findings was acknowledged by the cardiology team, where the impeller device was malpositioned, causing suction alarm. And so they had to remove the device and insert an IBP instead for venting. And despite adequate venting afterwards, this patient suffered from a major stroke and proceeded to brain death. And as I said before, we don't have time for to talk about the weaning phase. If possible, we would be happy to talk about it in a later lecture. And I'll have to skip through these slides. So the take-home message is that echocardiography is important in all phases of your device deployment, from the planning phase to placement phase to monitoring phase, and eventually in the weaning phase, which we did not have time to talk about. So in the pre-implantation phase, it's important to determine the severity of cardiogenic shock. Look out for any mechanical complications such as ventricular septal rupture, free wall rupture, or papillary muscle rupture, and be sure to look for those complications prior to placing them on ECMO support, because they would likely require rapid surgical intervention. And phenotype these patients according to their hemodynamic phenotypes into LV dominant, RV dominant, or biventricular cardiogenic shock. That's where you can be guided to know which device to use for each of these patients. And identify device-specific contraindications prior to implantation. So for placement, it's important to visualize the guide wire for both the venous and arterial side when you're placing the patients on ECMO, on VA ECMO, and always properly confirm that position is in the right position prior to dilation and placing the cannula. Monitor for any need for LV unloading. Look out for any risk factors or evidence of inadequate LV unloading, and try to do something before thrombosis actually happens, and also assess for any device-related complications so we can tackle them early and help with patient survival. And these are the references and some of the review articles that I would like to share with you regarding the use of echocardiography in patients on mechanical support. Thank you, and we are very happy to receive any questions or comments from the audience.
Thank you very much, Dr. Wincy. That was a very enlightening discourse on the role of echocardiography in ECMO. A lot of us don't have much experience with ECMO. Most of these devices are not available here. I think some of us do have experience with the intra-aortic balloon pump, but ECMO and impeller are actually not available in this part of the world. So most times what we do is just a theoretical knowledge. We don't really have much practical knowledge with the devices. However, it's a very interesting one, and I would like to invite the participants and members on this call to ask their questions. If you have a question, kindly signify by raising your hand so that you can be unmuted, and then you can ask the question. Otherwise, you can just type it into the chat box, and then we'll read out your questions for the presenters to respond. Thank you very much. Okay, so I have the first question here, which is, when is it safe to commence anticoagulation, and which agent is recommended?
So thank you for the question. I think in the guidelines, we are recommended to give a bolus of heparin during or after cannulation, followed by a heparin infusion. In our center, we don't really readily give the bolus heparin per se, for instance, for our ECPR patient or patient with severe cardiogenic shock, because we would anticipate that these patients will be going to, for example, PCI for AMI cardiogenic shock, where heparin boluses would be given. And so we would usually save that for the cardiologist to give. And after everything's being done, we'll put these patients on heparin infusion. So for the agent, currently the agent of choice in our unit and most parts of the world will be heparin, will be unfractionated heparin. Of course, there are risks of like heparin resistance or heparin-induced thrombocytopenia, but it's not a very common condition in our area per se. So for almost 100% of our patients, we put them on unfractionated heparin. And see if Tammy, with the best experience, has anything to add to that.
Thank you, Wincy, for the answer. I think just as a little supplement, I think the timing for the anticoagulation, it really depends on the balance of the bleeding and also the thrombosis risk. Because, for example, for those like ECPR patient or those with severe cardiogenic shock, if the patient is already very deranged and organ function, like having the deranged liver function, sometimes we'll withhold a bit and see the balance the bleeding risk. But of course, if it's like just elective VA ECMO, sometimes we'll put in the anticoag, starting the enoxaparin, starting the heparin earlier to prevent the thrombosis risk, because patients with a very low EF and after putting on ECMO, the thrombosis risk is actually quite high. And in our unit, we have you should also prepare like a gatroban as a alternative in case if there is HIT or other potential contraindications for the heparin use.
All right, thank you very much for the responses. I don't know if we have any other question.
I think there's another question on the patients on VA ECMO requiring dialysis. So I think there's recently a study on intensive care medicine where they studied these patients when you put them on VA ECMO with a renal replacement therapy circuit that is connected directly to the VA ECMO system or separately with a separate dialysis catheter. In our center, we have experience of doing both of these. And I think Tammy may have like more experience and explanation on which to use. It is something to do with the pressure within the ECMO circuit and also whether or not it's possible to initiate renal replacement therapy via the ECMO circuit.
I think this question, it really depends on the size of the cannula that you have put in. Like because of the, there are two ways, as Wincy mentioned, there like you can either use the ECMO circuit to do the dialysis, as well as you can put another like HD catheter for the patients. But in the ECMO patients, there are always higher risk like putting in a line, and also the access are very limited. So sometimes instead of using another like setting another HD line, we would like to use the circuit if it is possible. But it really depends, as Wincy said, it depends on the pressures. If like the because the CRT machine actually it is very sensitive to the pressure change. So if the return pressure is like too high, sometimes actually the CRT machine will have the alarm and you will not be able to like using the circuit. So it really depends on the circuit pressure and then whether you can connect the CRT directly to the ECMO machine. But preferably, we usually use the circuit if it's possible, because we just want to minimize the risk of like the putting a HD line and also like like wasting one of the potential access in case the patients need like a venting or other access, then reserving more access is better.
Thank you very much. We are waiting more questions, please. You can unmute yourself if you wanted to ask your question.
Owoade, can I say something? I'm thinking that
Yes,
those
please.
of you who are very experienced, who have started using these devices, should probably make your comment. Let's look at our experiences in our resource limited settings. Fumi is here. I think I'm sure she's used to it, and you as well. So what is your experience? What is your experience at your center?
Sorry, would you mind if I get your questions correctly, is that in a resource limited setting, how should we work on the MCS device? Is it the questions or?
No. Some of our colleagues here have used some of these devices. like the moderator has used it. So I'm asking them what are their experiences like, so that I probably would compare with what you've described and what they're experiencing.
All right, thank you very much, Mr. President. Thank you once again to the presenters. So like I said earlier, I don't have experience with the ECMO, but what we do have in our facility is the intra-aortic balloon pump. And one of the clinical scenarios I'm going to picture is that of a 60-year-old woman who came with who had a massive MI a week prior and presented in cardiogenic shock. Echo revealed ventricular septal rupture and apical dissection. So because she had multiple organ failure, we had to stabilize a bit before taking her in for the procedure. So, and the only available device we had was the intra-aortic balloon pump, which we were able to use to stabilize her, to correct some of the electrolyte derangements and optimize pressures enough for her to go into the OR. But if we had everything available, I'd like to ask Dr. Tammy, if everything were available, is the intra-aortic balloon pump the best device to use, or will the VA ECMO be preferable for this kind of patient?
Thank you for the question. This is a very good question, but I think it really depends on the patient situation. Like for example, the patient because is having severe MI. Sometimes, like if the IBP, of course, is good to like reduce the afterload for the like VSD and also severe MR. But it can like in very severe cases, sometimes like the aortic, like the patient is having very severe shock. IBP itself, it can only provide a very like modest support. Sometimes it may not be enough. But as mentioned, like for VA ECMO, sometimes the limitation is like because of the afterload. According to our experiences, because sometimes we have tried to put in an ECMO because the patient is having shock and we don't have enough time to screen everything, we put in that VA ECMO. If the patient has underlying severe VSD, there are some occasions that actually patients cannot have the aortic valve open because the afterload is too big, and then all the blood is shunted from the LV to the RV instead of going through the aorta. Because compared with the aortic pressures, like the aftergrade, the retrograde flow from the ECMO, the RV pressure must be much lower. And that's the problem for having ECMO inserted in the severe VSD case. I think for this kind of cases, the first thing we need to, before we put in MCS, any kind of MCS, we need to discuss with the CTS surgeon first. Because in our experience, like for those severe VSD, sometimes like the surgeon may want to have a delayed approach to repair this. And it really is like, as mentioned in our like presentation, the durations of support sometimes affect the decision of our like what kind of escalation we have. And then if first of all, if it's possible, like because as if the patient has severe shock, sometimes if like near cardiac arrest, I will still put in an ECMO. But before I put in everything, I will need to discuss with the surgeon plan. In case if I put in an ECMO, then I will I may and the aortic valve is not opening, will there be a surgical intervention for that? If the patient has a mild shock, maybe IABP is a better choice because it doesn't have the afterload problem created by ECMO, and it may be like if the patient is just a mild shock, then probably the IABP would be enough and a better one for this. But because of the like impeller, there's like intraventricular like defect, then it may not be too optimal if we put in an impeller. So my choice will be depending on the surgeon plan as well as how shocked the patient it is.
Okay, thank you very much.
Dr. Owoade, what was the outcome of your intervention?
Yeah, so we were able to optimize enough for her to go for the procedure, but intraoperatively, they found out that the whole left ventricle there was a massive ischemia, so they couldn't really salvage it. So what we just did was keep her on the pump while we tried to optimize till her eventual demise.
So, Dr. Tammy, in your center, I appreciated what you said, that probably IBP may not have been adequate for this.
If the patient is very
please, can you please mute Dr. Ladoku?
Go treat
So
yourself.
in your setting, oh my God. Dr. Ladokun, can you mute Dr. Ladokun? Dr. Tammy, so what additional effort could you have put in this case, probably to get a better outcome?
Because I think the outcome, according to case, is limited by the LV infarct. I think it really, because it really depends on the underlying cause. For this case, maybe the LV is severely infarct that possibly
Yeah.
the patients may not be even like improve even if we put anything. But if the patients, like as mentioned, if the patient is not very shocked at the beginning, the main problem may be just the pulmonary edema, probably I will put in IABP as well. But if the patient is having severe shock, I would put in ECMO. But according to the case, like the patients went into the surgery and find that he had severe infarct for the LV, then probably there's not really a possible like a better option for this case, because probably the patients need to wait for a longer period of time before she can put in any support. Like, because if there is a VSD, like the surgeon usually want the delayed approach, because they want the infarct well established before they put in any repair. But if they can't repair it, actually there is a limitation for the support for the both the IABP and ECMO as well.
Right.
Thank
Thank
you
you
very
very
much.
much, Dr. Tammy. Yes, please. So, do we have any other questions? I can't see any on the chat, and no one is asking any.
Professor Elizabeth is raising her hand.
Okay. Kindly unmute yourself and ask your question, please.
Okay, thank you. Good evening. Thank you so much for your presentation. So we have a patient currently who is a 33-year-old with Hodgkin's lymphoma that developed circulatory failure in the ICU. So now they notice that the heart rate is very high while the blood pressure keeps dropping. So, and she's on noradrenaline and dobutamine. And we don't have ECMO or any of these other circulatory support. What will you suggest in this scenario?
Thank you for your questions. I just want to clarify. So the only existing agent would be IABP, right?
Yes.
Because for IABP there's a main limitations, as we all knew that it's very it need to be paced across time against the cardiac rhythm. So if the patients usually like more than a heart rate more than 110, I find that the IABP is not really efficient, like because the timing is too fast, and then it's too fast for the balloon to be timed against the rhythm. So usually for more than 110, I find that actually IABP doesn't help really much in this case. So for example, because of the choice of the machine, so I think if I'm not sure about how's the exact patient's condition, but if possible, I would like to control the heart rate first, and then try to see, because sometimes the heart rate too fast itself will affect the cardiac output because it lost the atrial ventricular relationship. So I will try to control the heart rate if possible, and then and also it depends on whether it's sinus or sinus tachycardia or fast AF. So see whether we have any agents to correct it, and then if really want to use the IABP for better support, maybe it needs to control the heart rate first, and then in case if it's have frequent ventricular tachycardia arrhythmia or something like that, I may put in temporary pacing wire to try to overdrive the rhythm to see whether it helps.
Okay, thank you very much. Would you suggest the use of vasopressin in this scenario?
Thank you for the questions, but I would like to know what kind of underlying etiology for this failing heart.
Actually, they are suspecting that because of the lymphoma, She's having a kind of cardiogenic shock, but the real etiology is not well known.
I think for the vasopressin use, I think it really depends on the condition. But because vasopressin itself actually increases the afterload, and actually it will impede the cardiac output itself. So unless the patient is having like a very vasoplegia, so in sometimes I will try to use the vasopressin for some vasodilatory shock. But if the patient's heart cardiac output is already very low, and then sometimes put in a vasopressin sometimes will further suppress the native cardiac output. So I will be very cautious in using this.
Okay. Thank you so much, Dr. Tammy.
Thank you.
For sharing.
Thank you for your questions.
Thank you very much, Prof, for your questions. Thank you, Dr. Tammy and Dr. Wincy, for the presentation and also the responses to all our questions. So we don't have any other questions on the chat, and I can't see anyone's hand raised. So I'll assume that we don't have questions for the presenters. Okay. So in the absence of any other questions, I would like to thank the presenters once again. It's been a great pleasure and a very educative one having you have this discussion with us about mechanical circulatory support in critically ill patients. I'd like to hand over to the anchor for this session, Dr. Josiah. Over to you. Thank you very much, everyone.
Thank you very much, Dr. Owoade. We are grateful to our speakers for the excellent presentation, and I believe we have been enlightened in management of cardiogenic shock with respect to the use of mechanical circulatory devices. So I would like to invite a member of the ESCO for a vote of thanks. Dr. Owoade, could you please do that?
Hello, am I audible?
Yes, sir, we can hear you.
Yeah, thank you very much. Thank you very much, our presenter, for a very fantastic presentation. So, on behalf of the President, Intensive Critical Care Society, the ESCO, and the members, we wish to appreciate our presenter, Dr. Tammy and Dr. Wincy, for taking out time to come and actually deliver this impactful lecture. We really appreciate what you've done. I can see when the president was asking you the time in where you are in your country, and we are talking about you being close to midnight. It's a very huge sacrifice that we as a society appreciate. We thank you very much, and we are hoping that when next we call on you to still come and impart knowledge, which is actually one important thing that we need in this area. It's a new technology that is just coming in that many of us are not used to yet. We are still going to need more sessions on getting used to these machines. We are hoping that you will still make yourself available for us. Thank you very much once again. Thank you, and do have a lovely evening.
Thank you very much, Dr. Owoade. And just to wrap it up, I would like to invite Mr. President for his closing remarks. Dr. Joe, over to you.
Thank you. I thought we have a certificate for the presenters, Dr. Irene.
Yes, we have a certificate going to be delivered to them.
Oh, okay. Also, I want to acknowledge the presence of Professor Elizabeth. Elizabeth has been very consistent in all our meetings. But thank you very much for standing up for us at this time and being an inspiring leader. We are actually encouraged by your presence. Thank you very much, ma. And the general himself, as general left, general, you can't say anything before you leave.
Thank you very much, my president. I want to sincerely thank our two presenters. They have really dug deep into the annals of ECMO and also the cardiac aspects in the intensive care. I listened effectively throughout the two presentations, and it was awesome. I want to sincerely thank the organizers of this webinar series for bringing the two personalities to talk to us today. This is very interesting, and all the best to the ESCO. Thank you very much to all our distinguished members that are present today. God bless us all. Bye.
Dr. Irene, the certificates, please. Can you, before it's already into the next days for them over there in Hong Kong? I don't know. Can you display the certificates, or they're not available? Dr. Irene?
It will be delivered to them, sir.
Okay. Thank you very much, everyone who has spent time to attend this webinar series. It's been a very educative section for everyone. And it is just, and I know that we have cardiogenic shock or patients who present in very intractable circulatory shock in our environment. We experience all this. The main issue is availability of these devices and the knowledge to drive these devices. That is why for those of our members who have access to these devices, like at the African Medical Center of Excellence, and then Dr. Kotu, I'm sure you do it in cardiac surgery as well. With your knowledge, once in a while, you also brief us as well so that you get abreast of what is going on. Thank you, these speakers have done extremely well. They have woken up at this their late hour in the morning over there in Hong Kong to talk to us. I'm sure we're going to use them much more, to talk to you about the little effort we can make to get better outcome for those of our patients who present in cardiogenic shock. Most times we have issues with the cardiologist, but for us, we are supposed to be knowledgeable about the use of these devices, or even the use of inotropes and vasopressors. Maybe we're going to get them in a short while to talk to us about the use of these, maybe the chemical pharmacological interventions that we can actually use. Thank you very much, everyone who is here. Thank you, Dr. Longway. We are seeing you for the first time. Thank you, everyone. Thank you, Dr. Nike. We are appreciative of your effort to moderate this section, and Dr. Josiah as well. Good night, everyone. We want to see you again in the next series. Bye.
Thank you for having us.
Thank you. Bye.
Good night.
Night all.